I'm based at the London School of Hygiene and Tropical Medicine at the Vaccine Confidence Project. I co-lead it with Heidi Larson, and so the team at the Vaccine Confidence Project, we conduct global research on vaccine confidence, examining local and global dynamics, so that influence vaccine decision-making, and I'll go into a bit more detail during my talk. So while most people vaccinate, some groups or individuals delay or refuse vaccines. And I'm going to give you 3 case studies. So these are fairly well-known case studies. So in northern Nigeria, there was a polio vaccine boycott as Muslim leaders said that the polio vaccine was causing infertility and that it was a US-led conspiracy to depopulate the developing world. As a result, Kano State became the epicenter of cases spreading to 10 other countries, and we're still trying to eliminate polio. So the boycott was just under a year, but it had a huge impact. The other classic case study is with the MMR vaccine. So this is Dr. Andrew Wakefield. And so in 1998, Dr. Andrew Wakefield and colleagues wrote an article in The Lancet that stated that MMR vaccine could be linked to autism. And so since, so the article was published here in 1998, and then there was an amplification of concerns with media. There was a lot of media about this issue of the MMR vaccine, and coverage reduced to 79.9%, so below the herd immunity threshold. This is in England. As a result, so the Lancet article's been retracted fully, and Andrew Wakefield was struck off the medical register, but he's still fairly active, and even more so this summer. He met with Donald Trump, who also on YouTube says that vaccines are linked to autism. So there's this huge anti-vaccine group that's reassured that Donald Trump is on their side, and so someone's listening to us. So that's kind of worrying. This is an example of INVS study in France. So there was a huge outbreak in France in 2010, 2011. And here in this study, they looked at reasons for non-vaccination. So measles is not perceived as a serious illness because the parents weren't vaccinated when they were children. So they say, well, you know, I just got the disease, so why can't my children just get the disease? And so the risk of the vaccine is perceived as more serious than the risk of the disease. And there are some communities in France that have distrust of authorities, distrust of medicines or pharmaceutical companies. And also there are some communities that have a belief in homeopathy, and it's more natural to have the disease, build up your immunity with the disease than with the vaccine. And there's also been cases in Wales, we had an outbreak, and there's been a catch-up campaign in teenagers that didn't vaccinate during the whole Wakefield saga. And in the US, there was a Disneyland associated outbreak. So there were some cases of measles in Disneyland. And so some people traveled back to California. And so there was an outbreak there. And then the third case study I'll show is to do with the human papillomavirus vaccine. So in Japan, there were concerns about side effects after the vaccine. Some teenage girls had convulsions, seizures. Some had partial paralysis. There's a video as well on YouTube and Facebook of teenage girls having these episodes. So it's quite, when you see these videos, it's quite concerning. So what the Ministry of Health, Labour and Welfare did was they decided in June 2013 to stop recommending the vaccine. So doctors can't recommend the vaccine to their patients. So as a result, there's one-sided coverage, and it's all the concerns rather than a doctor saying, actually, well, the research so far has shown that it's a safe vaccine and that there's no link. There's been some big studies. And also there was compensation agreed for one family. So the public can see that as an admission that maybe the vaccine did cause it if the government's compensating that family. We did a study, and Japan were quite surprised to see that other countries were talking about what was happening in Japan. So the solid lines are the countries talking about what was going on in Japan. And because they didn't realize that people were talking about it, but generally it wasn't the public health authorities commending them. It was the anti-vaccine groups were saying, look what Japan's doing. They've stopped recommending it. That's what we should be doing in our country. And then Japan were articles talking about what was going on in Colombia and what was going on in the US as well. And so in Japan, there was these issues of seizures and fainting and POTS, CRPS, but there have been other concerns globally. So in the US, there were concerns about sexuality and abstinence. So parents thought, well, if I'm saying that I want to vaccinate my teenage girl with HPV vaccine, I'm saying it's okay to start being promiscuous and start having sex. There were issues about mandatory vaccines in the US and parent rights. So the Governor Rick Perry in Texas tried to mandate HPV vaccine, and then there was a whole backlash there because the industry were involved and it all happened a bit too quickly. In Colombia, there was mass fainting episodes of young girls, so that's another issue with them vaccinating teenagers. Is teenagers are more likely to potentially faint especially if you're all queuing up and the first girl faints and someone else, you might be more likely to faint as well. And then we did a commentary in the Lancet ID about India. So in India, there was a demonstration project looking at acceptability and feasibility of HPV vaccine in 2 states, in Andhra Pradesh and Gujarat. And what happened there was... Actually, it wasn't people from these states that were concerned about these demonstration projects. It was people from Delhi and around India that gathered and started building evidence against the demonstration project. So they started with their main reasons were why now, why this vaccine, the testing, cervical cancer testing programs not well funded. So why are you bringing in this expensive vaccine when you're not testing for the people that currently have HPV or have cervical cancer. Also, then there were issues about ethics. So, for example, there was one school of 200 girls and there was only one ethics form signed saying that these 200 girls could be part of this demonstration project. But they weren't listened to. They wrote a letter to the Ministry of Health and weren't listened to. So then eventually they gathered and had more people. And then they did a press conference on the World Health Day. And there were 4 deaths, because the issue when vaccinating so many people is that you'll have adverse events, but they're not linked to the vaccine. So they were saying these deaths were caused by the vaccine, and so the demonstration projects was shut down as a result of all of this, although the deaths have not been linked. So going back to vaccine hesitancy, what do we mean by vaccine hesitancy? So it's a behavior influenced by a number of factors, including issues of confidence, so you don't trust the vaccine or the provider. Complacency, you don't perceive a need for the vaccine. You don't value the vaccine. And convenience, access. And this was devised by the SAGE Working Group on Vaccine Hesitancy. So there's a continuum of vaccine hesitancy. It's not just refusing all vaccines. So there are some people that refuse all. There are some that refuse but are unsure. There are some people that accept some but delay some or refuse some. There are some that accept, but they're not quite sure about it. And then there are other people that accept all. So there's a continuum. You can't just put someone in a camp. Also, it depends on the vaccine. People change their mind as well over time, depending on what they've been exposed to. And then in terms of a more complex kind of model of vaccine hesitancy, so this was a SAGE model. So you have vaccine and vaccination specific issues. For example, the risk versus the benefit is a determinant of vaccine hesitancy. A new vaccine, people are more likely to be hesitant towards, for example. The role of healthcare professionals. So if a healthcare professional recommends a vaccine, people are more likely to vaccinate. In terms of individual social group influences, if immunization is seen as a social norm, people are more likely to vaccinate. Unless everyone's vaccinating, then you might get freeloaders that won't want to vaccinate. You need to have knowledge, awareness of the vaccine-preventable disease and the vaccine. Experience with past vaccination is a determinant of vaccine hesitancy. In terms of contextual influences, as you saw with the MMR study, so influential leaders can have an impact on vaccine hesitancy. communication media environment as well, policies, mandates. So there's a lot of, it's a complex system. So we carried out a systematic review on vaccine hesitancy in childhood vaccination. And so this was between 2007 and 2012. And what we found were the majority of the articles were in the Americas and the Euro regions, and not necessarily where the children are, and not necessarily where most of the vaccine hesitancy is. And the determinants are complex, context-specific. They vary across time, place, and vaccines. And few studies look at the kind of interrelationship of these different determinants. So I'll just run through these. So, for example, income in a study in Nigeria, low income was seen as a promoter, whereas low income in a different study in Nigeria was seen as a barrier. So it's very complicated. Education can be a promoter or a barrier. Cost, is a barrier. So longer distances to vaccination clinic is seen as a barrier. Extra time, administrative and financial burden for healthcare workers, a barrier. Encouragement or belief that immunization is a social norm is a promoter. Belief in scientific medicine is a promoter, seeing value in vaccination. If your health knowledge is influenced by myths or rumours, that's a barrier. Anthroposophist beliefs in alternative medicine, that's in the Netherlands, that's a barrier to vaccination. These kind of make sense, but it's worth bringing all the evidence together. So awareness of vaccine-preventable diseases is a promoter. Perception that the vaccine-preventable disease is dangerous is a promoter. If you've got confidence in the knowledge of your healthcare worker, that's a promoter. Whereas if you don't think the disease is severe, that's a barrier. So going back, I was thinking about, so my work is in vaccine hesitancy, and I was thinking back about, well, what about this perception of the full public health value of vaccines? How does this come into it? So we carried out 2 qualitative studies recently, and we tend to look at more reasons why people don't vaccinate rather than reasons why people do. But we do ask that question in our studies. So I looked into that data and I'll share that with you. So one study was looking at the Haredi Jewish Orthodox community in northern London. And with Public Health England, WHO and NHS England, we applied this tip. It's a tailoring immunisation programmes. It's a good strategy for identifying groups that are not vaccinating, trying to understand their reasons for not vaccinating, and then trying to figure out what are the best strategies to decrease hesitancy, to increase vaccination coverage. So in this community, there was a measles outbreak, and it was 4 times higher in the Haredi community than the rest of that borough. And so PHE analysed the measles outbreak and did a questionnaire, and myself and colleagues, we carried out some in-depth interviews with parents and key informants. So why? So we spoke to mothers of children who vaccinate and those who don't vaccinate. So for those who did vaccinate, what were their reasons for vaccinating? They trust doctors, so the doctors know what they're doing, and if it's said to be done, then it's to be done. They wanted to protect their children from disease. They wanted to prevent the spread of the disease. Anticipatory regret, so they'd rather vaccinate than regret not having vaccinated if their child were to get ill. They perceived the risk of the disease to be greater than the risk of the vaccine, and they didn't have any concerns. So, and then looking at this is the leaflet that's sent in the community. So it's targeted for them, so you don't have photos of people, and the information there is targeted to them to improve vaccination coverage. And I thought, let's see what content is in this information leaflet. So how does immunization work? Is immunization safe? Will giving my child so many immunizations at the same time overload their immune systems? That's one of the concerns in this community. Are the diseases that we immunize against dangerous? Isn't it better for my child to get the disease itself, to build up their own immunity? So we've seen that before. What are the common side effects of immunization? And why do we start immunizing our children at such a young age? So in this community, there's the perception that it's better to vaccinate after a child is 1 because they're too vulnerable and too young to be vaccinated. And one mother, when she went to see her healthcare provider, when the child was older, and she said, "Oh, I haven't vaccinated against this," and they said, "Well, no, well, it's too late now anyway." So she kind of thought, "Well, I'm glad I didn't do it." But so it's interesting. So here they're actually trying to these questions address the concerns of the community. So in a different study, we looked at, so in 2012, the Joint Committee of Vaccines and Immunisation advised that we vaccinate children in England in order to protect others at risk, since they're the carriers of disease. So since then, there's been pilots in more and more areas in the UK, and we did a study looking at reasons why parents weren't vaccinating their children. So we worked with some providers so parents who didn't fill out the consent form were contacted with an expression of interest form about our study, and one question was, why didn't you vaccinate? And this is the results of the expression of interest form. So we had 133 responses. So we were pleased that actually 24% either did vaccinate or wanted the vaccine. So when we're looking at these numbers, they're not necessarily against vaccination. They might want it or didn't do it yet, or they thought they couldn't because of medical reasons. And then the main reason for this study, but we wanted to tease it out of the results, was that this nasal spray has porcine gelatin. So there are communities that don't want to ingest pork, and so that they're not vaccinating. And then there were people worried about effectiveness and people that were worried about the side effects. And then this other category, the lack of the perceived need. So one of the years, the pilots was in secondary age children, so older children. So they just didn't see their child as vulnerable. So my child's healthy, strong immune system, low risk of catching flu. Quite a lot of parents said, my child's never had flu, so I don't need to vaccinate them to stop them getting flu, to pass it on to others, because they just don't get flu. Or if they were to get flu, they'd be at low risk of complications and better to build the immune system with disease. So when we spoke to parents, so here everyone didn't accept it, but we asked the question, what would make you more likely to accept the flu vaccine in the future? And the main question was really, they said more information about the program, more information about the vaccine, since it was new for children. Has the vaccination really made a difference? That will influence next year's decision. If there was an increase in risk of complications from flu or an epidemic, they'd be more likely to vaccinate. So when pushed, a couple of mothers, if it was an epidemic in the elderly, no, I probably wouldn't vaccinate. But if it was an epidemic in children, then yeah, I'd vaccinate to protect my family. And in terms of the parents that weren't vaccinating for more religious reasons, reassurance from religious leaders may help. No one said definitely, they said, oh, I might consider it, or other people might be more likely to vaccinate if there was reassurance from religious leaders. And then looking at the leaflet, so it's a bigger leaflet, but there are these 5 points, and I thought, let's have a look and see, does it explain the full public health kind of perception of vaccines? So the nasal spray helps protect against flu. It's been given to millions of children worldwide, has an excellent safety record. So that's more reassurance about safety. It's painless and easy to have because it's a spray. So people who might have been put off by the fact that it was an injection aren't going to be. Flu can be really serious, especially for children with medical conditions like heart disease and diabetes. If your child gets flu, you may have to take off time off work to look after them. So there is this added kind of, well, you don't want to take time off work. But when probed, the mothers were, well, one said, oh, that's a guilt trip. Of course I'm going to look after my child if they're sick. So it's interesting. And then another mother said, oh, but some mums don't work. So saying that, so you're going to, I don't know, you're not going to cover, you can't make everyone happy with your messages. And the last one, protecting your child can stop flu spreading to other children and the family, especially babies and grandparents who might be at high risk from flu. Although when probed, so the parents I spoke to, mostly their parents they vaccinated once against flu and then were ill, and they didn't really want to vaccinate against flu and didn't see themselves at risk, so yeah. So moving on, this is a study done by Frederick Buter in 6 countries in Europe. Who do people turn to? So the light grey is where respondents would go to find medicines information. They go to their GP, pharmacy, they do go to the internet. But when you look at trustworthiness, Luckily, the internet's down here, but most people trust the GP and the pharmacy and the local hospital. So that's reassuring. And in terms of healthcare providers, we did a systematic review looking at vaccine hesitancy in healthcare providers, but also their role of addressing vaccine hesitancy. So it reflects Frederick's study that HCPs remain the most trusted advisor and influencer of vaccination decisions. But the capacity and confidence of healthcare providers are stretched. There are time constraints, increased workload, limited resources, often inadequate training and information support. So healthcare providers need more support. And in a review on strategies addressing vaccine hesitancy we saw that communication tool-based training for healthcare workers is an effective strategy, as well as social mobilization, mass media, non-financial incentives, although that was in studies where the people that were part of the trial were very poor, so it was extra food was given, and then so they were more likely to vaccinate. Reminder recall-based interventions, we also found that's a useful strategy. But few strategies have been evaluated for effectiveness because generally multi-component dialogue-based strategies perform better, and it's very difficult to evaluate them. And then I thought this would be interesting to add. I'm not going to go into too much detail, just to show when someone decides, shall I vaccinate or not, there's a lot going on. So there's all the information that's coming in, and then some people decide straight away without thinking too much. Other people talk with their husbands, with their family, with their friends. So then there's risk perception, so the risk of infection, the risk of vaccine adverse events, and then these modifying factors, so your attitude, identity, what you should do, what others do, habits, barriers. This all influences whether you choose to vaccinate or not. And then you could choose to vaccinate, but then you don't actually go on to vaccinate. So there's that side as well. So just to finish, really, we tend to look at vaccine hesitancy, but should we be focusing on the reasons for vaccinating and the full public health value of vaccines? Thank you.